Hello, my dear. I'm Dr. Ala Musbah, Professor of Obstetrics and the Gynecology Faculty of Medicine, Mansoura University. The topic of my lecture today about gestational trophoblastic neoplasia. So, what we want to discuss this day: definition, the classification of gestational trophoblastic disease, the etiology, the epidemiology, pathophysiology, histopathology, and the clinical presentation and the workup to reach a diagnosis, and lastly, the treatment of gestational trophoblastic disease. Let us start our journey with the definition. What is the gestational trophoblastic disease? This is a group of uncommon conditions associated with pregnancy. Histologically, it includes pre-malignant, partial and complete molar pregnancy, as well as malignant invasive mole, choriocarcinoma, placental site trophoblastic tumor, and the epithelioid trophoblastic tumor. The malignant forms can arise from after any type of pregnancy. I mean, full-term pregnancy, molar pregnancy, miscarriage, and so on, and are collectively known as gestational trophoblastic neoplasia. The gestational trophoblastic disease spectrum has recently been expanded to also include atypical placental site nodule, as 10 to 15% may coexist with or develop into placental site trophoblastic tumor and epithelioid trophoblastic tumor. So what is the classification of gestational trophoblastic disease? Please remember, we have two big categories: the hydatid form moles, which is a benign placental tumor with malignant potential, like complete mole and partial mole. And the other big category, gestational trophoblastic neoplasia. This is a placental tumor with malignant behavior. Okay? Like what? For example, invasive mole, gestational choriocarcinoma, placental site trophoblastic tumor, and the epithelioid trophoblastic tumor. Okay, what is the etiology? The etiology related to gestational trophoblastic disease, the placental trophoblasts are the origin of molar pregnancies and gestational trophoblastic neoplasia. Remember that placental trophoblasts are made of cytotrophoblast cells, syncytial trophoblast, and intermediate trophoblast. Okay, this is the three component of placental trophoblast. Okay, so from cytotrophoblast and syncytial trophoblast, hydatiform mole and the choriocarcinoma can arise. From intermediate trophoblast, placental site trophoblastic tumor and the epithelioid trophoblastic tumor can arise. Okay, so there is origin for each type of them. Okay, in the majority of cases, complete molar pregnancy result from fertilization of ovum without maternal chromosomes. This ovum of the mother or the wife has no chromosomes, okay? And fertilized by one sperm. And this sperm duplicate its DNA, resulting in 46XX androgenetic karyotype, okay? So, all these chromosomes are paternal, okay? Approximately 10% of complete moles are 46XY, resulting from fertilization by two sperms. So, complete mole can happen either fertilization by one sperm to ova with no chromosomes, and this sperm duplicate to reach the full number of 46XX, okay, or two sperms fertilizing the ova without chromosomes, resulting in 46XY chromosome, and this occurs only in 10%, okay? But the majority occur with one chromosome duplicated, resulting in 46XX, okay? Okay. Even though the nuclear DNA is entirely paternal, mitochondrial DNA remains maternally derived. Still, there is maternal DNA derived from the mitochondria. Although the ova has no chromosomes, but there is DNA related to the wife or maternal from the mitochondria. Okay, what about partial hydatiform mole? They are mainly triploid, resulting from fertilizing of healthy ovum by two sperms, okay, resulting in 69XXY. Okay, so triploid, because I have here two sperms with their chromosomes and one healthy ovum. That's why it is triploid. And you can see my lecture about molar pregnancy previously done. Okay, what about the epidemiology? Gestational trophoblastic neoplasia is found more frequently in Asia compared to Europe and North America. The incidence of hydatiform mole in most parts of the world, it is 1 per 1,000 pregnancies, while gestational choriocarcinoma occurs in approximately 1 in 20,000 to 40,000 pregnancies. Approximately 50% of choriocarcinoma present after term pregnancy, while 25% after molar pregnancy, and the remainder after other gestational events, like miscarriage and so on. Okay, following a molar pregnancy, the risk of an additional complete and partial mole rise to 1 to 2%. What about if it happened twice, two molar gestation before? The risk is increasing to reach up to 15 to 20%. And the risk is not lowered by change of partner. Remember this. Okay, some repeat molar pregnancy are caused by familial or sporadic biparental molar disease. Okay, hydatiform mole is more frequent at the extremes of reproductive age. Okay, before 15 and above 45. So the extreme of age is a risk factor for molar pregnancy. The risk increase after the age of 35, and there is 5 to 10 times increased risk after 45 years. Teenagers have twofold risk of having molar pregnancy. What about diet? Diet deficiency of beta-carotene and animal fat is considered to be etiological factor for complete mole, but not for partial mole. Okay, go to the pathophysiology. The choriocarcinoma are malignant epithelial tumor. It secretes HCG. High level of HCG is reported in cases with choriocarcinoma. Intraplacental choriocarcinoma can also happen and is probably the one responsible for metastatic disease occurring after term pregnancy. And the majority of neonatal, remember this, the majority of neonatal choriocarcinoma arises from metastatic spread from intraplacental choriocarcinoma. Okay, what about placental cytoplastic tumor? This is a malignant tumor. Form uterine lesion, but less hemorrhage and necrosis and the lower HCG concentration than choriocarcinoma. Okay, what about the histopathology? As regard complete hydatiform mole, there is 46XX chromosomes or 46XY. There is no fetus or embryo, expanded swelling of the villi and expanded trophoblastic hyperplasia. On the other side, the partial mole, there is triploid, 69XXY, 69XYY, 69XXX. All these are varieties. Okay? There is abnormal fetus or embryo. This is the difference between the partial mole from hydatiform. In complete mole, there is no fetus. In partial mole, there is abnormal fetus or embryo. Okay? And here also there is central swelling of the villi, central trophoblastic hyperplasia. What about the histopathology for gestational choriocarcinoma? Diffusely penetrative growth involving the endomyometrium. The tumor cell recap chorionic villus trophoblast of different types and are arranged in biphasic to triphasic growth arrangement. Sheets or cords of mononuclear tumor cell surrounded by layers of multinuclear sensitive trophoblast, there is lymphovascular tumor thrombi present at some cases. Okay, what about the histopathology for placental site trophoblastic tumor? Tumor cells invade myometrium with vascular or lymphatic invasion. Focal hemorrhage and necrosis are seen in nearly half of cases, while the transmural myometrial invasion is in 10% of cases. Is perforation can occur? Yes, it can occur in some cases. What about the histopathology for epithelioid trophoblastic tumor? The tumor usually creates discrete nodule or cystic hemorrhage masses that deeply invades the surrounding tissue. There is hemorrhage, necrosis, ulceration, the fistula. Characteristically, this epithelioid trophoblastic tumor express nodular, expandable, gross, approximately uniform, medium-sized tumor cell organized in nests, cords, or large sheets. What is the clinical presentation of gestational trophoblastic disease? You should know at the start that due to our routine use for ultrasound and measuring beta-HCG level, patients with complete molar pregnancy are commonly diagnosed early in gestation, and they are usually asymptomatic at the time of diagnosis. But what if there is presentation for this gestational trophoblastic disease as regards the molar pregnancy, for example? Okay, there is the common clinical presentation is vaginal bleeding. Okay, in 46% of the cases, and usually between gestational age 6 to 16 weeks. Large size of the uterus according in relation to the date, large for date. And this is one of the differential diagnoses for enlarged size of the uterus in relation to the date. Okay? So large for date occurs in 24% of cases. Hyperemesis gravidera. 14% of cases complain of hyperemesis. So please, if you have a case with hyperemesis, please exclude the presence of molar pregnancy or gestational trophoblastic disease. Okay, this is the common clinical presentation, rather than being asymptomatic and discovered accidentally during measuring the serum beta-HCG or doing ultrasound. Okay? Okay, what is the less common presentation? Less common presentation include hyperthyroidism manifestation, early onset preeclampsia, and abdominal distension due to cecal lutein cyst. Very rarely, women can present with hemoptysis if there is chest metastasis or lung metastasis, or may complain of seizure due to brain metastasis. This is a very rarely. Patient with partial mole, usually not diagnosed before uterine evacuation, and has to histological examination of curettage specimen after incomplete or missed abortion is required for the diagnosis. The majority of patients with partial mole, 75% of them complain of vaginal bleeding. They generally present later than those with complete molar pregnancy. Okay, complete molar pregnancy are typically associated with high level of serum beta-HCG level. Nearly half of the patient with molar pregnancy before evacuation of the uterus has a titr about 100,000 or more milli international unit per milli. Nonetheless, such elevated beta-HCG level happen in less than 10% of patients with partial hydatiform mole. So, complete mole has a higher level of beta-HCG than partial mole, okay? In most of the cases. Okay. Any woman who develops persistent vaginal bleeding after pregnancy event is at risk of having a gestational trophoblastic neoplasia. Take care about this point because it is important. Okay? A urine HCG test should be performed in all cases of persistent or irregular vaginal bleeding lasting more than 8 weeks after pregnancy event. Okay, what is workup? What's your investigation needed? Serum quantitative beta-HCG, pelvic ultrasound, chest X-ray for lung metastasis, complete blood count, clotting studies, prothrombin time and partial thromboplastin time, renal and liver function test, blood grouping and RH, thyroid function test if you are suspecting hyperthyroidism, like TSH and free T3 and T4. Ultrasound is the primary tool used for gestational trophoblastic neoplasm. Yes. Complete mole characteristically show uterus filled with heterogeneous mass. We call it snowstorm appearance or honeycomb appearance, with the absence of fetal movement and the presence of cecily-10 ovarian cysts. Okay? Unfortunately, these findings are not visible in the first trimester. So the manifestation more clear after the first trimester as regard the ultrasound finding. A false negative and the false positive rates are high with the use of ultrasonography, specifically in case of partial mole. Histological examination is necessary to reach the final diagnosis. Okay? As histological examination may not be practicable to be done after every termination, at least do test for HCG 3 to 4 weeks after management to make sure it returned to the normal range. Okay, this is very important. Post-molar gestational trophoblastic neoplasia often expresses no symptoms or distinct finding on ultrasonography. Hence, correlating with HCG level is necessary to reach the diagnosis. MRI is usually not important in the routine evaluation of gestational trophoblastic neoplasia. However, it is needed in some cases like that with atypical presentation, recurrent cases, or in cases of placental site trophoblastic tumor or epithelioid trophoblastic tumor, because sometimes this is difficult to be diagnosed, so MRI could be helpful in such cases. According to FIGO staging of gestational trophoblastic neoplasia, there is 4 stages. Stage 1, gestational trophoblastic tumor strictly confined to the uterine corpus. Stage 2, gestational trophoblastic tumor extending to the adnexy or to the vagina, but limited to the genital structures. Stage 3, gestational trophoblastic tumor extending to the lungs, with or without genital tract involvement. Stage 4, all other metastatic sites. Let us go to treatment of gestational trophoblastic disease. We will take it in summary, then we will take the treatment of gestational trophoblastic tumor after that. Okay. Cervical dilatation and suction curettage is the best method for treatment in case of molar pregnancy. Okay? Okay. The use of oxytocin infusion period to completion of removal is not recommended. This is as reported by the guidelines. Okay. Post D&C HCG level monitoring is essential to ensure no disease recurrence. Remember, you will do a pre-test before evacuation to know the tetri before you do evacuation. Then after you do evacuation, you will do the beta HCG tetri again and do follow-up. Should I give the patient with Rh negative anti-D prophylaxis? Yes, it is recommended to give anti-D prophylaxis in Rh negative non-sensitized women. What about chemotherapy? Sometimes of gestational trophoblastic disease can be well treated by chemotherapy, either single or combined regimen. Okay? Some of the used chemotherapeutic agents include methotrexate, etoposide, actinium-YCD, cyclophosphamide, cisplatin, and vincristine. Is there a rule for hysterectomy? In cases with chemo-resistance or severe diseases, hysterectomy is the most common treatment option used. So, in certain condition, hysterectomy is indicated. In chemo-resistance or severe disease. Okay. There is some controversial treatment, like what? Like prophylactic chemotherapy. The use of prophylactic chemotherapy instead of monitoring HCG level until disease clearance criteria are met will decrease the use of intense chemotherapy regimen and boost the chance of complete healing. What about second DNC? To do DNC again. The concept of this modality is to perform a second DNC after molar pregnancy evacuation if the HCG level remain non-reassuring. If you did test for beta HCG and not decreasing in the normal way, so you may need another D&C. However, if there is high risk of uterine perforation or hemorrhage, a second D&C must be not performed if you are afraid from perforation or hemorrhage. What about drug resistant to gestational, in case of gestational trophoblastic disease? Approximately 0.5 to 5% of women experience drug resistant gestational trophoblastic disease and unfortunately may die as a result. Pembrolizumab was one of the studied drugs to be used in this condition, and the studies showed that it represents a valuable new approach for treating drug-resistant gestational trophoblastic neoplasia. Okay, what is the optimum follow-up? Following diagnosis of gestational trophoblastic disease, as regard for complete molar pregnancy, if HCG has reverted to normal within 56 days of pregnancy event, then follow-up will be for 6 months from the date of uterine evacuation of molar pregnancy. Okay? If HCG has not reverted to normal within 56 days of the pregnancy event, then follow-up will be 6 months from normalization of the HCG level. This is as regard the most recent guidelines published by the Royal College of Obstetricians and Gynecologists. Okay, what about the partial molar pregnancy? Follow-up for partial molar pregnancy is concluded once the HCG has returned to normal on 2 samples at least 4 weeks apart. So you will do 2 samples, 1 month apart. If both of them negative, the patient is considered cured. Okay, let us go in details for treatment of gestational trophoblastic neoplasia. You should know that the treatment generally by chemotherapy. Okay, so chemotherapy has the major role in its treatment. The best regimen depends on the stage and the classification. In 2000 FIGO staging and the classification, a risk score of 6 and below is classified as low risk, and above 6 is considered high risk. And so the regimen of treatment will be changed according to the patient is low risk or high risk. Okay, this is the FIGO scoring depending on what age in years, antecedent pregnancy, interval months from and of index pregnancy to treatment, pre-treatment serum beta HCG, largest tumor size including uterus, size of metastasis, number of metastases, previous failed chemotherapy. And we have score 0, 1, 2, and 4. And let us see what we are going to do with such patient with low score and high score. In low risk gestational trophoblastic with a score from 0 to 4 with gestational trophoblastic neoplasia can be treated with one of the single agent methotrexate or actinomycin D protocols. For example, methotrexate and folinic acid protocol 8 days. You can give the patient 50 milligram methotrexate intramuscular on day 1, on day 3, on day 5, on day 7. While folinic acid can be given in a dose of 15 milligram orally 24 hours after methotrexate. I mean, it will be in day 2 and day 4 and day 6 and day 8. And this repeat every 2 weeks. There is another regimen, actinomycin D pulse 1.25 milligram per square meter intravenous every 2 weeks. Actinomycin D 0.5 milligram intravenous for 5 days every 2 weeks. This is different regimen. What about if I have a higher WHO risk score between 5 and 6? Between 5 and 6. Not reaching above 6 and not lower than 5. Between 5 and 6. and the clinical histopathology diagnosis of choriocarcinoma are both associated with an increased risk of resistance to single-agent chemotherapy. Lowering the threshold for the use of multiple-agent chemotherapy in these otherwise low-risk patients can be considered. So, this is very important. If associated, this score between 5 and 6 and associated with choriocarcinoma, increase the risk of resistance if I give single chemotherapy. So, multiple agent chemotherapy should be advised in such a condition. After the HCG level has returned to normal, consolidation with 2 to 3 more cycles of chemotherapy will decrease the chance of recurrence. The overall complete remission rate is close to 100%, and this is good news. What about high-risk gestational trophoblastic disease? Those women with a score above 6, according to the FIGO, as I said before. I should give her multiple agent chemotherapy regimen. Give me example, like etoposide, methotrexate, actinomycin D, cyclophosphamide, vincristine. What about if I have a case with ultra high risk gestational trophoblastic neoplasia? Ultra high risk. Among the high risk group, as defined by the FIGO staging and classification, a subgroup of scores of 13 or greater. Those who have score 13 or greater, we call them ultra high risk. Also, we call ultra high risk for patients with liver, brain, or extensive metastases. Do poorly when treated with first-line multiple agent chemotherapy. Unfortunately, this group. So, for those with massive disease, starting with standard chemotherapy may cause sudden tumor collapse with severe bleeding, metabolic acidosis, myelosuppression, septicemia, multiple organ failure, and any or all of which can result in early death. So this group, if I give the traditional multi-agent chemotherapy, may have a very bad prognosis and the early deaths may happen. So to avoid this, what I'm going to do, the use of initial gentle rather than full dose chemotherapy seems logic. Indeed, induction etoposide 100 mg per square meter and cisplatin 20 mg per square meter on day 1 and 2, repeated weekly for 1 to 3 weeks before starting the normal chemotherapy, appear to have eliminated early death. So you should be wise with such group, with ultra high risk, with a score 13, and with massive metastasis. For those patients with liver metastasis, with or without brain metastasis, or a very high risk score, the etoposide and the platinum, EMA, or another more intensive chemotherapy regimen rather than EMA-CO may yield better response and outcome. For such high risk patients, longer consolidation with 4 cycles of chemotherapy should be considered. If there is rule of surgery in case of gestational trophoblastic neoplasia, hysterectomy, yes, can be considered in uncontrolled uterine bleeding. However, I have another solution, like what? Like uterine artery embolization. Okay? But if not available, hysterectomy is a good choice because I have an uncontrolled bleeding and I wanted to save the life of the patient. Okay? Laparotomy may be needed to stop bleeding also in organs in case of metastasis. In organs like what? Liver, gastrointestinal tract, kidneys, and spleen. Neurosurgery may be needed also in case of intracranial hemorrhage and there is mass and there is increased intracranial tension due to metastasis. Is there any rule of radiotherapy in gestational trophoblastic neoplasia? Radiotherapy has a limited rule. except in treatment of brain metastasis, although its efficacy compared with intrathecal methotrexate is controversial. What about placental site trophoblastic tumor and the epithelioid trophoblastic tumor? It needs special concentration about these two tumors. Both are less chemosensitive, unfortunately, than choriocarcinoma. That's why hysterectomy is the primary mode of treatment in most cases, and surgery also plays an important role in metastatic disease. So, in case of placental site trophoblastic tumor and the epithelioid trophoblastic tumor, hysterectomy is a primary line of treatment, and the excision of metastatic tumor also is important. If fertility preservation is desired in such conditions with placental site trophoblastic tumor or epithelioid trophoblastic tumor, especially localized lesion, I can do conservative management like what? Like uterine curettage or hysteroscopic resection of the mass and the chemotherapy. But if the mass is diffused, affecting the uterus, I cannot do fertility preservation. I should do hysterectomy. So if it is localized, I can do localized excision, hysteroscopic resection, and uterine curettage and chemotherapy. But if it is diffused, I cannot do fertility preservation. I should do hysterectomy. In advanced stage, protocols like EB-EMA or TETB can be considered. Interval from antecedent pregnancy of more than 48 months seems to be the most significant adverse prognostic factor. What about follow-up? After treatment of gestational trophoblastic neoplasia, follow up by measuring serum beta HCG, and you should do monitoring every month for at least 12 months. This is very essential for surveillance of relapse. Reliable contraception must be used throughout this period, like combined COC, combined contraceptive oral pills, for example. Women who undergo chemotherapy are advised not to conceive for 1 year after completion of treatment. After she completed her treatment, 1 year more, okay, to give her a chance for planning for pregnancy, okay? Future fertility, is it affected? And the pregnancy and the offspring, are they affected in case of gestational trophoblastic neoplasia? They are not affected, fortunately. Although psychosocial and sexual counseling may be needed for some patients. What about the long-term outcome of women treated by for gestational trophoblastic neoplasia? Fortunately, the outcome for women treated for gestational trophoblastic neoplasia is generally excellent, with an overall cure rate close to 100%. Further pregnancies are achieved in approximately 80% of women following treatment for gestational trophoblastic neoplasia with either methotrexate alone or multi-agent chemotherapy. But you should know that there is increased risk of premature menopause for women treated with combination agent chemotherapy. Women, especially those approaching the age of 40 years, should be warned of the potential negative impact on fertility, particularly when treated with high-dose chemotherapy. Thank you, everybody. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine. Please remember my 3 books: textbook of obstetrics, textbook of gynecology, and the contraception handbook. Thank you.